Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast Podcast. My name is Terry Fletcher. It is the last Tuesday of the month in April, so you know what that means. That means we are at Top 10 Tuesday. So in my topic today, I wanted to talk about prior authorizations. We will have a couple of coding questions, but I just thought it would be helpful because this is such a big headache right now for practices. We have to do it, but it doesn't necessarily guarantee payment, does it? So what is the point, as a lot of practices have asked me. But we'll look at both sides, both the physician and the payer, and then I want to give you the top 10 ways to hopefully assist you to reduce your burden, administrative burden, when getting prior authorizations. So for the coders and billers and physicians out there, please invite your front desk staff, your pre-authorization staff, hopefully to listen into this episode, and it will help you not only from a financial standpoint, because it'll show you how to basically streamline a couple of things, but also kind of to let them know that we're here for them, that we understand that there's some things going on that need to be cleaned up when it comes to prior authorizations. But first, the Codecast Podcast is also brought to you by pare, a Danish software company leading a global centralized terminology solution for interoperability solutions. It isn't about cutting the human out of the equation so much as giving the human tools to improve healthcare. Carecom.com. This week, I also wanted to shout out and say hi to Victoria and Amy with a Y. I like how she spells her name, who listen every week without fail. They sent me some really nice feedback this week through email. And also a colleague of mine, Sean Weiss, he's with the National Society of Certified Healthcare Business Consultants, a membership that I also belong to. And I just appreciate him so much. He shouted out my podcast this week. It's been a good milestone. We hit 50,000 listeners, and it's really awesome when your industry fellow consultants respect what you're doing. There's enough work out there for all of us. So it's just nice when you get that from a fellow consultant. But if you want to read an informative healthcare blog, besides mine, of course, because I know you all go and read my blog, you're sitting there going, oh, wow, I need to go read her blog on her website. But go to Doctors Management. It's actually doctors-management.com and search the Compliance Guy blog. It's really good. And that's Sean Weiss. He's also on Twitter. And so you can find him on there as well. And he's got some good stuff out there. So just a shout out to those people this week. I really appreciate you. Okay, so prior authorizations. Well, the biggest thing is we know they're not going anywhere anytime soon, but drastic changes do need to be made, and we're finally seeing some movement on the horizon, not just with Medicare, because there's been a lot of discussions about it, but also with some of the commercial plans as well, because the burden isn't just on the physician's practice, but it's also an expense for an insurance company. So they have to really take a look at it as well. So a couple of things I just want to preface this with so that we can look at both sides of the issue. It's no fun to just really say and complain about what we're dealing with from physician services and hospital services. We have to look at both sides of the equation. Otherwise, we're not making a credible argument by just complaining about what we're not getting, what we're dealing with. And so I want to give you a little bit of background. So it'll give you some understanding of the research actually that's being done on this topic of prior authorization and where the movement is within the payer industry. So in April 2018, a study from Government Accountability Office found that Medicare prior authorization programs saved Medicare between $1.1 and $1.9 billion since 2012 through a reduction in unnecessary utilization and improper payments. So they're not going to stop doing something when it comes to pre-authorization. It's not going to end. We're trying to get it more streamlined. Now, the American Medical Association also did their own research, and they estimated in a 2017 report that clinicians and staff spent an average of 14.6 hours per week on prior authorizations. That's a full-time staff member if you also consider not just getting them, but receiving them and then implementing them. Not only does this process take time away from patients, but 78% of clinicians reported in this AMA survey said that the delay can result in patients then abandoning a particular course of treatment. So AMA, along with the American Hospital Association, American Pharmacists Association, American Health Insurance Plans, MGMA, Med Group Management Association, and more associations, they've really petitioned for change. The petition really is to get the prior authorization process streamlined and standardized in the process. So having technology and new technology, this is really paving the way to move the process along. But the director of the Health Information Technology Policy at MGMA, he's been talking about this loudly, and he's talking about, the current work that's underway to automate the prior authorization process and really looking at these efforts, and they're being headed up by the Council for Affordable Quality Healthcare. They call them CAQH. So according to this healthcare organization, 90% of communications between payers and providers is still done by phone and fax. So that really adds up when you're considering that there are around 77 million prior authorizations done manually every year. So automation of this process could cut the cost performing these transactions almost in half. They're talking about an estimated savings of nearly $7 per transactions between payers and providers. That's huge when you look at the big picture. Also, in part of his report, he was saying that automating these communications depends on when CMS will release a standard for the mandated 278 transactions. So CMS has promised that these standards for some time will be released and hopefully have some kind of a process that could be automated between payers and providers with data pulled from electronic health records. But the future of prior authorization needs to be in real time, and it should be a discussion, not just a transaction. If we can automate that discussion, it can really save time. Think about how long we wait once we do or put in for a prior authorization. And one way technology may help speed along that prior authorization process is through the Fast Healthcare Interoperability Resources. This is a draft that came out, and it's a standard for electronic health information exchange. A company, Health Level 7 International, they actually have been working with a lot of major stakeholders in healthcare to launch a project that moves clinical data, and it basically moves it in a way where there's one prior authorization type. They're going to try to make it so it's not always different for every single payer. Now, Medicare and Medicaid have said, we're looking at this effort, but we have tried to create our own document requirement lookup service. Of course they have. Okay. Nobody wants to play in one pool, but they're saying that they really need to look at a new workflow for prior authorization. And this process would work directly with electronic health records. So currently, when a provider orders an intervention, there's a back and forth process, as you know. The new approach that they've been working on would involve an automatic trigger in the electronic health record when a physician places an order that would send a transaction to the health record and to CMS to find out if prior authorization is even required. So the system would offer a clinical documentation template sent by CMS outlining what is needed to justify the ordered intervention and prove medical necessity. So a lot of the times with prior authorization, especially I'm in Southern California, as you know, we have something called a TAR, a treatment authorization. And this is something that we have to get for our Medicaid or Medi-Cal. And it's a guessing game. Okay. So, you'd never have to, this would make it where you never have to guess what information is necessary to show that it's medically indicated. And this will also keep the physicians from, I hate to say making anything up, but trying to push something through because they feel that this would probably be covered, even though it's close to being covered, but not quite. And unfortunately, I do see that a lot. One of the most infuriating challenges for physicians in obtaining prior authorization is really for prescriptions and testing. So in the eyes of physicians, prior authorizations, they tell me all the time, this is nothing more than insurance companies inserting themselves into care-making decisions that are creating problems for both doctors and patients. And really a lot of physicians view prior authorizations as an attack on their autonomy, their years of training, their ability to care for their patients. Plus, there's the time wasted and the revenue lost due to haggling with the payers over the approval for drugs and tests. And I was reading something recently in medical economics where physicians basically were saying that prior authorizations are ruining medicine at this point. Prescriptions are expensive, and prior authorizations are an easy way for an insurance company, in their opinion, to save money. So the process is made and the purposefully burdensome so that the physician or patient will just give up and either use a cheaper alternative or forego treatment altogether. So that's where we have a little bit of a problem. Sometimes the patients are tired of waiting, and then they basically say, okay, I'm not going to get any treatment. And that's where it definitely has a huge impact on patient outcomes. So in that study in December in 2017 for AMA, reading on further, it said 86% of physicians report that prior authorizations have increased during the past 5 years. And 51% said significantly, to the point where they feel that they do have to have a full-time employee for it. The health insurance industry said that they need this authorization. This isn't a tool adopted by health plans and also government-sponsored healthcare programs to ensure that patients get the best care and there's not overutilization. I mean, in my opinion, the prior authorization protects patients, ensuring that the treatment is safe, medically necessary, and appropriate. But the reason that this is a problem, it's because a lot of physicians are paid based on RVUs. And that means what you order, what you perform, and it's based on basically what you generate. And so instead of looking at it always as health insurance providers are being trapped by prior authorizations, the payers are really trying to figure out a way to streamline, and the doctors should be on top of this as well, and collaborate between the healthcare provider and the clinician and the hospital and the payer to streamline a process so that the prior authorization process isn't what's the word I'm looking for? It just doesn't handcuff you so that your patients can actually get the care that they need. But I noticed that one thing, especially when I am setting up practices to assist them, and I do a lot of startup practices and talk to them how to start their prior authorization process. I note that especially when there is a big surgery or a big procedure, when the doctor has to get on the phone with the insurance company's physician, that requires spending time to first educate the reviewing MD or DO's information so that they may not be familiar with the specialty, and they may be a family practice physician who has no idea why a patient needs to have a heart cath that could lead to an interventional procedure. So I hate to call this, wasting physicians' time and nursing time, but these doctors that are reviewing some of the authorizations, they need to have insight, or there should be a doctor on staff that is that specialty and not just a general practitioner, so that it can really speak to the doctor's decision and understand that the responsibility of care is the doctor who's performing the procedure, not the physician who's saying, okay, yeah, we're going to allow it for payment. And so there's a med-legal responsibility to the ordering physician that the physician that, let's say, approved it, they don't have. And so there's a lot of burden on the requesting physician, and that's where their frustration can really stem from. And both individual and institutional healthcare providers, again, must hire people just to manage these prior authorizations and get through that process, which can be not only burdensome, but can also impact, patient care. So by putting the burden of lowering cost on physicians through increasing numbers of prior authorizations, insurance companies are detracting from patients' care. So most physicians agree, and again, according to the AMA survey, that more than 90% said that prior authorizations have had a negative effect on patient care, either by delaying the care or, again, causing the patients to abandon treatment altogether. Most of the time, you have to wait at least one business day for an authorization to be complete. But I'm seeing a trend where I would say at least a third of authorizations or prior authorizations, you have to wait 3 business days or longer. Or how many times have you tried to put in for an authorization, you call to find out the status, and they say they never got it? That's a real, oh my gosh, you want to have my head spin around. That really does it to me. So that time lag really creates a barrier to patients receiving the care that they need. And it just makes physicians and clinicians and staff having to jump through more hoops to try to get that care for their patients. So trying to get this, and again, I kind of go back to the interoperability and trying to streamline and interface communication between physicians and payers is the only way this is going to work. So physicians need to communicate effectively with patients, though, first, regarding prior authorizations. It's often better to address the matter proactively with the patient rather than wait until the treatment may possibly be denied. So what you want to do is explain to patients who may be unaware of the prior authorization process that insurance coverage for some medications, tests, referrals is very difficult to obtain because the insurance company makes it a challenge for the physician and the staff to push it through. And there's not much you can do at this point, as this is dictated by the insurance. And this is a conversation with the patients you're going to have. As for medications, try to encourage patients to use medications that don't require pre-authorization if it's possible. Once it's understood that prior authorization is required, it's important for physicians to, again, educate the patient on that process and the possibility that the authorization could be denied. They need to understand this up front, that the prior authorizations take time and that it could mean a delay in care, but hopefully not an abandonment of their care altogether. So let me offer 10 ways to reduce the burden of prior authorizations. I'm not saying it's perfect, but I am saying it could help you in the future. So the first one is assign specific staff. One of the things I like to do when I go into a practice and really overhaul their central billing office is I try to get experts in a particular payer. So navigating the prior authorization process, it's difficult enough, especially when each payer has their own process. So try to assign specific staff members to act as liaisons for specific payers. They can learn the process and become experts on various plans, and therefore navigating the process quickly and relatively easy. And then you don't have to worry about saying, okay, what does this payer actually want? Number 2, use technology when you can. So many insurers have started to offer online pre-authorization processes, and some electronic health records will even integrate into formulary lists. So technology cannot be beat when it comes to reducing the time and administrative burdens spent with prior authorizations. Number 3, evidence, documentation, and generics. So know why you are choosing the therapy and medication you have chosen. Document why you have chosen it and back to your decision with evidence-based practice. So knowing what's on the formulary is great, but if you need to venture off the formulary, and we're talking about medications, make your case known, the generic options, and have the documentation to defend your decision. It also doesn't hurt to have a resource at the payer organization to turn to when you need to make an appeal. Make friends. There's nothing better than having a friend in low places, let me tell you. And then pre-populate forms. That's a big one. Trying to reinvent the wheel every single time, that can be an issue. So number 4, for each payer, there is a process. And for every process, there is a form. So pre-populating forms can save time. Practices can have pre-populated forms ready for each payer based on their own processes, and then fill in specific patient information for the individual request being made. And really train your staff how to do that. It's going to streamline so many things for you. Build relationships, it's a comment I just made. It's always nice when you have someone on the inside. As with any vendor or supplier, it can be the easiest way to find solutions when you have a specific person to turn to when there's a snag in how you're trying to get your authorization. In addition to assigning specific staff to manage prior authorizations for each vendor, have those staff members identify a source within each payer that hopefully can help them navigate the process and address any problems that may arise. You'd be surprised how open the payers are to talking to the same person as well, because they want to build a relationship so they're not having to relearn staff members. And then when we're talking about training your staff on the authorization process, when it isn't possible to have a staff member assigned to navigate the process with each payer, take the guesswork out by documenting the steps of prior authorization with each company. From prior authorizations to approvals to denials and appeals, having a written process or a guideline to follow with each different payer can save time and frustration for not only the clinical staff, but your business office staff. One of the biggest reasons I think people fail in their job, and this is just my professional opinion, is their lack of training or direction. And when you can outline this kind of process from a training perspective, everybody's job gets easier and there's a lot less headaches. Now, this one may be kind of simplistic, but one way to manage prior authorizations is to eliminate the need for them altogether. Create a directory. Create a directory or spreadsheet of what is permitted under the payer's plan. Reference that directory when a plan is being made for a patient, keeping in mind what interventions or medications would require authorizations or prior authorizations. And it's amazing where if you have that reference guide, then you can go back and just say, okay, this one doesn't need it, this one does, instead of just trying to remember. I know that seems a little bit simplistic, but it definitely will help you. Now, number 8, I like. This is something that came up with United Healthcare and with Humana, and it's called Get a Gold Card. So think of it as an easy button for prior authorizations. Some clinicians who have a proven good track record in ordering tests and medications may be able to earn what is called a gold card from certain payers. This recognition is given by some payers to clinicians who have a proven history of using medications that are on the payer's formulary or are not high-cost options. Not all plans offer it. Find out which ones do, but it never hurts to ask. They're not going to promote this, so make sure you ask. If the insurance company has a program like that, make sure you ask. Have your office manager make a list of insurers that offer that gold card service. Makes a huge difference. It's almost like you're a VIP in getting your prior authorizations. Now, this next one kind of goes with what I was talking about when I was prefacing the whole prior authorizations. But number 9, give patients a plan. Sometimes, despite efforts to stick to a plan's formulary, patients are met with a surprise when they go to fill a prescription at the pharmacy. So educate patients on their options, including self-pay discounts, and help them create a plan when roadblocks are encountered. Actually ran into that this week. I needed to refill a prescription for something I was dealing with, and I put out my neck a little bit, and the muscle relaxer they gave me was not available. They said there was no manufacturer date when it was going to be available. And I hate taking medication. I mean, I hate it. So I'm just like, great. So I had to call my doctor and say, okay, can I get something different? And she said, yeah, sure. We'll just call in something different. Well, the other one was $20 copay under my plan. This one was $83. And I was like, wow, that better be some great drugs there, because I'm sitting there thinking, did I really need to get something different, or should I just wait it until who knows when? But the pain was a little bad and I have to travel this week. So I was just like, okay, I guess I'll just suck this up. But this is what patients need to know. They need to know that not everything falls under their copay. Otherwise, there could be definitely an out-of-pocket that they don't anticipate. So let them know. So number 10, and this is something that I know this is tough on your physicians because they're pulled in every different direction. But I would ask them to be an advocate. While it's not an everyday task that will improve clinic efficiency in the short term, clinicians should advocate for change and ask their legislators and medical benefit providers to develop a consistent method of authorizing medications, interventions, treatment, diagnostics, etc. So there's several different physician advocate groups out there. Your doctor can just say, you can put my name on something, send them a letter. You don't have to go specifically to a legislator. Go through your group, go through your society, your associations, because a lot of these groups have sent dozens of core quality measure requests, but there's more work to be done. So the goal is to have a set core of quality measures and standards with a threshold, but a standardized process that eliminates the need for piecemeal prior authorizations across the spectrum. We need to have a standardized, streamlined way to get this done without costing us so much money. And so hopefully you find those top 10 tips helpful today. Now on to our coding questions. So my first coding question today comes from one of my Hawaii subscribers. It says, Terry, we would like to perform a self-audit of critical care claims in our practice to fix any coding issues we may have and improve our bottom line. But we have no idea where to start. Can you help us? If we find any kind of pattern or problem, then we'd like to contact you and contract with you to then take it a step further and look at it from an external audit. Okay, so first, and I'm happy to help on this because I think you should always do an internal look before you sub out anything. So you will need to collect a random sampling of critical care claims from your physicians, review the chart documentation and determine which code you would report for the service, then check what the physician actually billed, keep a tally of any discrepancies so you know what to discuss with the doctor later. when you can offer the physicians tips on how to code it right or how to document correctly. Once you perform the self-audit, you can create a schedule of internal audits going forward, expanding that out to other codes beyond critical care. So consider the amount of resources you can devote to the audit while simultaneously conducting day-to-day business. So the more often you can audit, the cleaner your claims will be. At a minimum, you should conduct an internal audit at least twice a year. That's what I recommend. So after you've prepared your staff for the auditing process and determine when you'll perform an audit, you'll need to define the focus of the audit. So what do you want to accomplish with your audit? And here's what I recommend. First of all, the audit scope. Which providers, services, date range, and payers will it address? How to select your charts. Will you fix this process for each provider? Will you randomize the chart selection? And then pull charts and organize documentation that's supporting, such as printout of physician notes, account billing history, CMS forms, and remittance advice. So don't forget that an audit is much more than coding. It involves documentation, coding, billing, data input, denials management, and office processes following and the process following policies and procedures. And so you're auditing because you want to see if your physician is following protocol. This is a compliance issue as well as it is coding. So hopefully that was what you were looking for. Next question is from an Ohio member. It says, I was told that a separate ICD-10 code is not necessary or required to report a modifier 59, but we never seem to be able to get paid with this modifier unless we have a separate diagnosis. Can you advise? Yeah, I know this has always been a problem because the CPT book says with the 59 and also with the 25 that different diagnoses are not necessarily necessary, but it says it's a distinct procedural service. So how do you describe a distinct procedural service unless you have a different diagnosis? Now, Medicare puts out a fact sheet that says, and I'll quote, use of modifier 59 does not require a different diagnosis for each HCPCS or CPT coded procedure. But private insurers typically maintain policies that list similar statements. Unless you have a payer that specifically tells you that it won't pay for a 59 claim unless you use a separate diagnosis, you also want to ask to see that policy in writing. Now, you can try and appeal these claims, but what I would do is not only would I make sure first that I have medical necessity and a clearly documented separate nature of the two services, and sometimes that is done by the different diagnosis, but don't forget that CMS, so Medicare, has replaced numerous numeric modifiers with HCPCS modifiers. So in particular, the 59 modifier. We've got 4 separate, what would they call subset modifiers. The XE is a separate encounter. The XP is a separate practitioner. The XS is a separate structure. And the XU means unusual non-overlapping service. And so I mentioned before that I have a modifiers webinar coming up on May 22nd. And so you might want to consider that because we will not only give you examples, but lead you through the process when it comes to modifier madness, as we like to call it. So just consider that. But in answer to the question, it is really tough when it's a 59 modifier. Our coding questions were brought to you today by Keck Medicine of USC, over 500 internationally renowned physicians at a leading California academic medical center, keeping you healthy, on track, and doing the things you love. The Keck Effect, keckmedicine.org. So my personal tidbit this week, it's actually a mixture of personal and business. I'm headed up to Portland, Oregon to present advanced cardio and advanced gastro seminars. And I get to see my family. So my brothers and my sister-in-laws, and I have a couple of nieces and nephews that live up there. And I'm really looking forward to that. Also, if you're ever in the Portland area and you want to go to a great restaurant, try Portland City Grill. It is at least one of my top 3 restaurants in all of the country. And I've been everywhere. So something to definitely try out. Great view and just the best scallops I think I've ever had. So everybody go out and make it a great day, make it a great week, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.